Hello, everyone tonight who's decided to join in. This is Dr. Tal Wilkins here. We're going to be going over the injection molding technique for Viva Learning and GC America. And so I'd like to thank everybody who's come out tonight. Um, if it's anything like me in my practice, it's a really hectic time of year, and every single patient who has needed something done in the last year and a half has suddenly decided they need to come in to see you right now. So I know it's very, very hectic and busy at this time. So if you're here tonight, I do appreciate that. So we're going to get right into it, and we're going to start talking about injection molding. This is actually something that's been very, very beneficial in my practice, and it's kind of really changed things for me. So we're going to get right into that. And the first thing, what we have is this patient. What would you say if I took this patient and in one session was able to perform this for this patient? As you can see on the patient's right side, their tooth number 4 was actually fractured, and it actually came out. And the reason being is he didn't have a lot of guidance, and the chipped, worn teeth, the diastema in his mouth. And after just one appointment, we were able to go from what we see on the left to the right. And that was actually done by using the injection molding composite. Another patient, this is a grandmother who came to me who was simply completely tired of her teeth. She no longer wanted to have her teeth and wanted dentures, but she also told me that she just could not tolerate dentures any longer. And with that, she decided that she wanted to have all her teeth taken out. Now, the first thing that I'm thinking is a patient who can't tolerate partials wants to go straight to a denture, and that's not the type of patient I want to be working on. And so what I did from there is I then talked to her and I said, what if we actually try to prolong these teeth and do it in a manner that's not super expensive, because she couldn't afford crowns. And also in 2 appointments, by splitting up the maxillary and the mandibular, I was able to go from here to there. And what we did is I did talk her into some partials after we did the injection molding on the existing teeth that she had. And honestly, things worked out really well. It took a good bit of working on the partials to make those comfortable, but we were able to restore and kind of preserve her teeth. And I think she looks very, very good from there. And also another patient who thought his dentition was hopeless. You can see the major, major wear. And with a combination of injection molding in the anterior and a few strategically placed crowns, we were able to go from this to that in a matter of just a couple appointments. And so this is actually what I'm able to do is I'm doing this with injection molding. We're going to talk about all the ways that you can actually do that during this presentation, the steps and the materials that it takes to do so, and everything along with that. Now, here's a video that's going to show you, in essence, how I go about doing this. Now, it's a little bit different, and I'll make some notes of that a little bit later, but this shows the basics. So, like I said before, my name is Dr. Tal Wilkins, and I practice in Aiken, South Carolina. I am a general dentist. I do a lot of full mouth dentistry, and it's kind of evolved in that over the years. If anybody wants to take a picture or a screenshot of this page and you want to reach out to me directly, I'm more than happy to talk to you with questions after this or anytime, or on Instagram at Dr. Tal Wilkins or talwilkins4@gmail.com, or my phone number. Like I said, this is where I'm from. This is Aiken, South Carolina. It's close to Augusta, Georgia, not too far from the border of Georgia, right there where the Star is. And one of the big claims to fame in our area is the Masters tournament. We're about 20 minutes from the doorsteps of the Masters golf tournament. Also in Aiken, South Carolina, where we're from, it was voted by Southern Living one of the South's best towns, and that was several years ago that we that was. This has been a truly great place to live. Another big thing we're known for, like I said before, is golf courses. This is Old Palmetto, which is the oldest golf course east of the Mississippi in the United States. And one of our local boys, Kevin Kisner, one of the pro golfers that's out there. We also have Sage Valley Golf Club, which is home of the Masters for junior golfers. So, like, golf is a big, big thing in our area. Another big thing that is good for Aiken is also horse racing. In the springtime, we have what's called the Triple Crown, and it starts with the Aiken Trials, which is the all-out racing. And then the next weekend, we have the Steeplechase, which is the horses jumping over the steeplechase. And also then it follows it up with finally the big polo matches. And so, it's the sport of kings. Horse racing is a sport of kings, and I'm going to show you about that because the reason that's important is, you would think that this area has plenty of money, and there is money in this area. But honestly, when it comes down to doing full mouth dentistry, where you're telling someone that it's going to cost a car what a car would cost for you to get the work done, most people can't afford that. And so, like, I have to find out ways to be able to do that without breaking the bank for people. And I've been able to do that with injection molding and to phase them into treatment. This is my family. My wife in the middle, Leah, she's actually a dentist, and we practice together. And that's my son and daughter as well. And these are my two knuckleheads, my two pets, and her name is Millie and Trump. And that rounds out my family. And this is my practice. It's called the Center for Dentistry. And I have been in Aiken since 2008. So getting straight into injection molding, what is it exactly? Okay. And so simply put, what injection molding is actually where you take a flowable composite and you then do a wax up, and you'll utilize a clear PVS impression material and then squirt through into that PVS impression material onto the prep teeth a flowable composite that will then take on the exact shape of the wax up that your lab took such diligent time to do, and you cure through it. And so it's exactly what it says. It's an injection molding technique, and that's done in many different types of industries. Now, what are the benefits and uses of this? Well, one of the big things is I can take it and I can immediately stabilize a deteriorating dentition, like I showed you earlier, especially in the case of those difficult cases. I'm pretty much doing this additive only, and so usually I do these types of cases with no anesthesia or very little anesthesia possible. It's also a cost-effective method of doing it. I'm charging typically what the cost of a buildup is, and you can do these things fast, so you're not utilizing that much time, and you don't have a lab bill associated with it. Like I said, I can perform a full mouth rehabilitation in 1 to 2 appointments. It's also a very forgiving material. It's composite. And so if I'm testing out a new occlusion or altering the vertical dimension on a patient, I can utilize that to see what's going on. I can add it, I can subtract it, I can take it away, and really there's no harm that's been done to the tooth. And another big thing is it allows me to meet the patient where they are. Usually for financial or time constraints, and we can actually do these type of procedures, change the vertical dimension, change the bite or the aesthetics, and then my patients are usually on a clock. I tell them 3 to 4 years they can get by with this, and they need to swap the teeth out as they fail, or they can swap them out at their leisure typically one tooth at a time for a more durable type porcelain restoration. So it's been very, very good in that aspect. So where do we start with all of this? Well, the first thing we're going to start with the wax up. You need to take very, very good records of your patient, photographs. You can go through smile design and global diagnosis and the other things to determine where you want the teeth to be and how you want them to look. But you're going to get a wax up. And the whole thing with the wax up is, I don't know how you can do anything without a wax up. You're going to plan your work, and from that, then you're going to work your plan. Now, in the past, I would spend the money to actually have the lab do this beautiful wax up. And, the technicians are highly skilled, and they have all this secondary and tertiary anatomy built in. And all I would do with these wax up is make a lingual PVS putty matrix like this and just kind of push it against the back of the back. And that's what I would take to the mouth. I would then put it into the mouth and it's build up lingual shelves like I did on this patient for composite veneers. So you can see the thin layer. And then you would then layer composite on composite to kind of get the effects of the dentin up underneath and the translucency until you go all the way through and you wax it to full contour. But then you still have to come back and then add in the secondary and tertiary anatomy with what's going on. And the whole thing was, I'm like, this is crazy. Why not utilize the entire wax up, especially the facial portion, which is what the patients are seeing. So if you're talking about, what are the most important factors when it comes to smile designer or when it comes to a tooth? Well, going from the most important to the least important, the most important thing is the silhouette, and that's simply the shape. Then the surface morphology, and that's actually the characterization and the bumps and grooves of the tooth. Then the value, translucency, chroma, and hue. What's crazy in dental school, what's the first thing we're taught to do when you start to see a patient? First thing we do is we grab a shade guide. And the way traditional Vita shade guides are set up is set up to where the hue, we're picking out the hue. And honestly, the more important thing is actually the value. If you look here, it's way up the list. Now you can rearrange your Vita shade guides to be in order for value, and there's ways you can look that up online, ways to do it. But really, the most important thing is the silhouette and the surface morphology, and that's the way that the light reflects off in the shape of things. And so when we're talking about silhouette, again, it's the shape and then the surface morphology. The shape of the anterior teeth are defined by the area that reflects the light directed onto it. And so that's what's important. And by doing the injection molding technique, you're able to actually take every bit of that the lab has done for you or digitally has been done for you, and to then transfer it to the patient's mouth in an effortless manner. Now, what we're doing these days is, honestly, I feel the best way to do these types of things is doing a digital wax up. The digital wax ups are great because you can actually, you can add as many teeth as you want, and you can simply deselect teeth to take them out of the wax up. So I'm utilizing exocad primarily, but you can also do it digital wax ups in 3Shape, and there's several other types of DSD software out there where you can make these things. But I will say that digital works best. And what you're going to, and you'll see in a minute, what we're going to do is from the full wax up, you can actually see how much addition we're doing on this patient by taking away the amount of, I'm not going to say it's not the translucency, but like minimizing out the full anatomic wax up on top. You can see the length of the teeth and the shape and where they are up underneath. And then after you get the full wax, you're simply going to deselect every other tooth. And you're going to understand in a minute why this is important, because we're going to injection mold every other tooth and then come back and do the other every other tooth model with the full wax up. And the reason you're doing this is this allows you to place Teflon tape in between the teeth so you don't lock the teeth together and the patient can floss, so it makes it hygienic. Now, some other benefits of the digital molding, digital wax ups is you can look at you can use a digital articulator and you can see where everything is touching. You can also see in some of the areas where you may have to do a little bit of reduction or change some things around from the model up underneath. in these areas, you can even measure exactly how much you need to take away with the slice feature, as you can see in the bottom right-hand corner of where things will be sticking out. And so I know in that area, that's going to be outside of the realm of where I want the tooth to be. And in this case, this patient was almost in a crossbite. And so what we did is I did the injection and completely changed it over into more of a regular bite and did a little crown lengthening on this as well. So now that we have our wax ups, then we're actually going to move and go into the 3D printed models. Typically, you can have your lab order this for you, or you can do them yourself. I myself actually utilize Sprint Rays 3D printers, and I'm going to do most everything, even the design in-house. But one of the things with the 3D printed models that you have to look at is the lines. The way 3D printers print, they print a layer at a time, and you can actually decide how thick you want the layers to be. And this actually matters when it comes to cleanup a little bit later on, because anything that you actually print, it will then be picked up into the clear PVS matrix. So you can see the lines from this PVS matrix that was made. And then when you go to injection mold, those lines will be in there. And so that just means there's going to be much more finish work that you have to do in polishing that you're going to have to do as you move along. And so here's an older model that I did utilizing 100 microns for the 3D printing. And you can see the flash this around and the two teeth that I actually injected molding. And this is upside down, but that's tooth number 7 and number 9. And so that actually takes a good bit of cleanup to do afterwards. So what you want to do is you want to have your print setting to 50 microns instead of 100 microns. And so basically whatever your printer does, use the finest printer settings to where it's at least 0.03 surface layer height. Now, when you do that, you're going to be minimizing. So you can see on the left, that's this one model printed at the 50 micron layer. On the right, it's a 100 micron layer. And you can see the difference in the layers. So you're much better off utilizing the 50 micron layer because it's going to make it much, much easier when you take it to the mouth and finish things. Also the materials, and also before I get into that, a lot of times what you want to ask for with your wax up is you want to do an additive only wax up. You want to take what you have and just have them to add to it. That way you're not doing, you're doing very, very little subtraction or taking away of the tooth. And by doing this, it'll allow you plenty of room for the injection or the flowable composite to move and flow around the tooth. Also, a lot of times I will say wax it up to the full contour like that and then add a 0.2 millimeters more on the facial surface. And that makes it where things are much more smooth. From there, once we have our wax up, we're going to move on to some of the other materials. And the first thing is actually clear trays. There's several different companies that sell the clear trays. I think I got these from Cosmodent, but you want clear trays with no holes in them. Okay, so you can get these clear types of trays, but they actually have the holes where the matrix, the PVS material is going to lock into that. You don't want that because you're going to be peeling out that layer. And here is also, like, sometimes I will put my impression after I've made it on the wax up into a pressure pot like I showed in the video. And so I cut just the little tongues off of the impression trays. And then when you get done, you're going to peel the actual PVS material out of there. The next thing that we're going to do is we've been talking about the clear PVS material, and what you have, there's many different companies that have it. Cosmodent has the RSVP, and I think there's 7 or 8 different ones now. GC has Exoclear, and that's currently what I use the most. I'll show you why I like that the best. Clinician's Choice has a brand called Crystal Affinity. And also, Colzer has one named Mimicil. Now, if I took these 4 types of clear PVS matrix, and they're called like bite registrations, but you can use them for impression. It's just they're very viscous and they're thick. Well, I took all 4 of these and actually I kind of squared them out on a glass slab and put them on top of a book to take a look at it. Now, if you take a look at this book, you can see the Cosmodent's on the left, the Clinician's Choice second from the left, then the GC, and then the Colzer. So they all have little different shades. a different type of opacity as well as the clarity. And for me, if you look, you can see the GC is the most clear. I've used them all. They all work perfectly fine. So you can decide whatever you want to do. But as we're kind of going through again, you can just see the differences in the different ones. And actually the one that's the most opaque is the one that I utilized the most early on, and it worked well. But that's the GC there, and you can actually read through that. Then also putting it against a black brown, again, you can see the opacity of each one. And for me, the GC is the clear winner when it comes to these. And so from there, we're going to make it the impression to where it's going to be even thickness on all sides, as well as an even thickness down near the incisal edge. If it gets too thin, those are areas where the flowable composite could distort. Now, something else I will do sometimes, instead of using a regular stock tray, is you can make a custom impression tray. And a lot of times I will do a PVS putty over top of my wax up. I then do a suck down, a hard suck down over top of that like you see there. And when it comes out, you actually have a custom impression tray for the one that you're working for. And you're probably thinking, well, that's a lot of work to do, and you're wasting a lot of money with your PVS putty impression to make that. But I utilize it for some other things. But here you can see you make the clear impression tray of the full wax up model. So from that, I then will sometimes, and this is the earlier case that I showed you with the 6 anterior veneers, you can actually just take some Bisacryl and flow it over top of, and put it into the PVS putty that you made, that you utilize to make the clear impression. But then you can utilize it and take that to the teeth. I utilize this for trial smiles, so you can show the patient what you're going to do for them beforehand, and it kind of helps to, not sell the case. That's not a good way to say it, but it brings value to what you're doing for the patient. I will then sometimes, like I said, just take the PVS, and I'll actually utilize prep reduction burrs to go over top of that. And you can see that's what I've done here. And then once the PVS or the Bisacryl is actually removed, you can see how little preparation I have to do to get down to where we're going to be the same thickness of material throughout. I mean, just very, very minimal prep. And these are the final preps. We've stayed completely in enamel, and you're going to have your best bonding to that. And so it works well. And I will say that almost the overwhelming majority, like 90% of my injection molding cases, I'm doing with no anesthetic, as long as I'm not getting too close to the tissue. And like I said, we're staying within enamel, so we don't have to do anything. So a lot of times my preparations are simply rounding over the incisal edges, taking away sharp spots from wear, and just I'm utilizing just fine diamonds and sandpaper discs. And the last of getting to the materials, we're getting into what we actually utilize for this. And so this all started out for me with what we call Genial's Universal Flow by GC. Now, this product is no longer available in the United States, but I'm putting it in here because there's a few things to know about it, and it is still available in Europe. But the Universal Flow is a very good product, and it was the first one that came out that has these characteristics. What's good about this, it has a feature, it has 200 NM strontium glass fillers that are homogeneously dispersed throughout the matrix. It's the filler particles that make this special, and also the way that it's actually bonded together within the resin matrix. And you can see it at the top, how fine it is compared to the competitor A and B of the microhybrid composites or the nano composites. You have different size materials, and what that does, it makes it highly, highly strong, and it makes it very, very highly polishable with the Genials. And as I said before, the fine, the 200 nanometer strontium glass product, it makes it where you have high strength, it's very aesthetic, it polishes very, very well, and it has very high gloss retention. Another thing with that, it has a low shrinkage stress, and so it makes it strong. It's very, very good. And the higher filler loading, like I said, the filler is 69% of filler. throughout it. So it's going to wear like a conventional composites. And this has actually been shown to do better than some conventional packable composites. And also with it being dispersed in a nano-sized fillers, it still handles like a flowable. So it's truly a unique product. This is a slide that was shared with me by Nate Lawson of UAB, and they did a lot of testing on that. They're called the Dental Tube on Instagram, and you can see some of the popular flowable composites these days right here. And on the right is the Genio flowable injectable, and you can see how it stacks up. So it's highly fillable. It doesn't run and is not as flowable as some of the other ones, but that's actually a good thing because it makes it where you have less flash, coming out from the sides of the restoration where you don't want to have it. So it works really, really well. Truly unique product. Moving forward with this, GC learned what the majority of dentists were utilizing this for. And so they discontinued on the far right the Genial Universal Flow. They've since divided it into 3 other products, and I think they've even added one more product to that. Something I haven't utilized yet. But you can see you have the bluest of the bulk, and then you have the flow, and then now on the far left is a universal injectable. I want to talk about each of these. So in the red syringe is GC's Genial Flow. It is used more as a base in class 2 composites or smaller posterior fillings. It's highly viscous. It flows easily handling. It's highly radiopaque, so you can see it. And again, I would say is utilized for more of like class 2 bases and small restorations. The next thing is GC's Genio Bulk Injectable. And this is used for actually just large fillings in the posterior. And it has a low viscosity, it's highly shapeable and stays put. So it's a little thicker than the red. Now, one of the cool things is actually it'll take on the color of the tooth around it, more so because it doesn't have as much of the color to it. But what that does, it allows it to you can fill and cure up to 4 millimeters with no veneering necessary. So it's, like I said, it's more translucent than other composites. And last but not least is now the GC's Genio Universal Injectable. And this is the second generation, I guess, of the Genio Universal Flow. And it's got just improved handling techniques, and the radio opacity is actually better than that. And so this is what we're utilizing these days. Also, you see here, there's many, many shades that they have for this. And, honestly, if you can't find it in that, then you're probably going to have some trouble with it. And you can also see that they all have a certain amount of translucency through it. So it will take on a lot of the shade of the tooth up underneath. So this is actually from GC. It's showing the difference of the flexural strength and the body wear of Genials compared to some of the other composites. And you can see that it works very, very well. And it's actually better than all the others in the category. But I'm always a little hesitant to just hang my hat on whatever it is that a company is selling me. Of course, they want it to be positive in their favor. And one of the things I did learn from this study is they actually did the stress testing against PMMA, like teeth made of PMMA. And so that's not necessarily what, we have in people's mouths and stuff. And so fast forward, I did found this article, and this was done in 2005 in the Journal of Prosthetics. And what it says, the relative wear of flowable and highly filled composites. And they were actually specifically testing the Genial's Universal Flow. And the conclusion, what they came up with was the newly developed Genio bulk injectable composite resins experienced statistically similar or lower volume depth wear than all other composites tested in a two-body wear simulation. So it did prove this better. What's even better is during this testing, they did this after water aging. And so materials will handle differently after they've been in the mouth or in a wet hydrophilic environment. And so they utilize that. They also use cyclic fatigue machines, which simulates chewing, and they actually put these material against real teeth. as the opposing type of material. So this is a much better real-time study for what it is, and the conclusion did go along with what GC's study found against the PMMA. And again, one of the big ways that they're able to do this is with the improved resin matrix. Many of the other particles out there that have the different particle sizes, it has to do with the silane that's around the particles. The particles bind more tightly to the resin matrix, providing a higher physical strength and higher wear resistance and improved handling properties. So GC has figured out how to take the individual particles and actually silanate them individually. Therefore, you have a homogeneous mix of resin. And sometimes the other ones, you'll have big globs of resin in certain areas, and then you have a big filler next to a small filler and more resin. And those are areas where you're going to have more wear in those. And that's what they've done. As I was talking earlier, though, the Genio Universal Flow is no longer available in the United States. But in case you still have some, or if anybody's tuned in from Europe, there's a couple things you need to know about that. And the big thing is the tip on the end. You can see how that's a plastic tip. And so this is what the plastic tip looks like. Unlike our regular composites, where the internal portion of the hub is what locks in to the syringe, it locks on the outside of the syringe. And so I would have to buy specially made syringes that had a metal tip to them like you see on the right. And they still make these. The reason you do that is the plastic tip on the left sometimes would bend as you're sticking it through the hole of your PVS matrix. And it can kind of be quite annoying at times. And so I would always recommend getting the metal tip on the other side. And again, as I was talking earlier, a regular flowable syringe looks like that on the left, and the one on the right is specifically for the Genio Flow. Again, but it's no longer available. Now we have the GC's Universal Injectable, and it's more in line with what we're using these days. And they actually supply the metal hub for that. You can bend the metal hub to kind of get around different areas, and it works much, much better with that. So like I said, this product is designed in mind for doing injection molding. Now, let's get on to the 12-step technique of how to do this. So first, we have our two different wax up. We're going to make a clear impression of the every other tooth model, all right? And so you're just going to make the impression, and you have it, you set it aside. The second thing we're going to do, we're going to make a clear impression of the full wax up model. So now we have full wax up model, clear PVS impression, and we have the every other tooth. From that, we're going to then utilize one of our metal hubs to actually punch a hole through the incisal portion of the teeth that you're actually going to be injection molding. So what I would do is first take the full wax up model, or not the full wax up model, but the every other tooth model, and the teeth that are fully waxed up on the every other tooth model, say it's 6, 8, and 10, you're going to poke a hole straight through that, okay, to the outside. And you're going to push it through there. Now, if you can see as you poked it through, you see the little piece of PVS that is coming out. You want to make sure you take that and clean that away, the little punch after each pass through. If you don't see it, you don't find it, it is probably still stuck in the middle there. And when you start to inject, you will inject that into the restoration. And you'll take it off and you'll look, everything is good. And when you're polishing, you're like, what is that? And basically you'll actually lodge that into your composite, and you have to cut it out and basically start over again. And it turns into a much more of a nightmare, because to try to injection mold one little portion of something that's already been done, it'll introduce bubbles, and it makes it very, very difficult. So you want to make sure you clean that out after each pass through. Then you will also then do the same thing on the full wax up model, but you're going to do it on every other tooth after that. So if you did it on the first model is 6, 8, and 10, you're going to do that on 7, 9, and 11 for that. And then we're going to move to the mouth. Okay, so then I'm going to do a minimal preparation of the teeth. Many times I'm going to a micro etch with 50 micron silica, aluminum silica, and just that helps the bonding strength. I'm also going to take sandpaper discs and smooth the edges of any sharp points because those can introduce like fracture points. Once you've gotten everything ready to go, you can see here the teeth are more hazed over, and that's due to the sandblasting. You're then going to take Teflon tape and you're going to actually put it around the teeth that you're not working on. The reason you want to do this is you want to try to keep the edge and the bond off of these teeth, and you don't want them to stick together. Now, this is the most difficult part of doing all of this. Sometimes you need to take some quick strips in between the teeth to make sure it's loosened up a little bit more than and for patients where it's like truly tight contacts, it almost gets impossible, but you need to just try to make it where you can kind of work it through, hold the Teflon tape nice and flat, and I actually floss it through. And then many times I'll make the Teflon where it's much longer than it needs to be. So when I floss it through one side, I can still hold either side and floss it through on the other side, and then pull it together, cut away the excess, and kind of bunch it all together on the back, like you could see behind the number 8 in that area. There's also sometimes I started using, there's different thicknesses of the Teflon tape. This yellow is actually one that's a little bit more thick, and there's different types used in different things. You can get them ordering off of Amazon. You can go to a dental company and order dental tape. It is thicker and made more for this stuff, but it's a lot more expensive. And I have found by utilizing the yellow tape, it's pretty much exactly the same. So once we have everything the way we want to have it, with the Teflon tape, you're then going to etch, prime, and bond and cure before you put everything on there. So here we are etching every other tooth, and then we're going to prime and bond just however you do that, and then you're going to cure each one of the teeth. From there, you're going to seat the matrix, and you're going to insert the metal tip all the way to the base. And you want to keep it buried as far as you can kind of get it in there. I would say up to the gingival third. And what you'll do is you'll start to inject the composite. You will actually see it flowing out and kind of moving around. And as it starts to fill up in that area, you're going to slowly withdraw it until you get all the way to the apex. One thing that's really important is to not take the hub out until it's all the way full. If you accidentally tape it out too much and you put it back in there, you're probably going to introduce a bubble in the area. So that makes it really difficult. So you can see here, injecting it all the way up. And then once you've done that with all of them, what you'll do is you can actually remove the razor matrix. You can cover it with glycerin and do your final cure, as you can see here. And so you can see on the right, like how much we actually did. You're going to have like little nipples off the end from where you punch through, and you're just going to smooth these up. So before you move on to doing the other teeth, what you need to do is you need to clean up the excess flash and smooth all areas. You need to pay careful attention to the proximal contacts. That's where it's difficult. So as you can see here, this is the case where I've done 7, 9, and 11. And you can see the excess is kind of going some different areas. And so, again, I'll use sandpaper disc on the incisal, and you're going to get it where it's nice and cleaned up. Also, 12 blades are something really good to use getting around those areas. If many of you haven't tried utilizing 12 blades in your anterior composites, they work great around the gum line interproximally. It's wonderful. Now that you have everything relatively smooth and shaped up with the others, then you're going to repeat the last steps 5 through 9, but you're going to do that utilizing the full wax up. See, so now you have every other tooth done. So that's going to fit into the full wax up. The remaining teeth are all the way to the full wax up. So what you have to do is now the teeth that you just injection molded with, you're going to now cover them with the Teflon tape, and then you're going to go forward. So you can see actually I took a little bit away in the anterior in this area, and we're going to wrap the Teflon tape around. Everything's ready to go. Etch, prime, and bond. Inject. Cure. And here we are. And you can see there's a lot more flash in this area. And that just happened to be how this case worked out. One of the things that I've learned over the years, because this is actually the very first case that I did this with, is to actually kind of hold and pinch your thumb and your index finger on the labial and the palatal side, kind of more in the tissue area. And that'll kind of pinch things off and make it where you don't have near as much flash to clean up. And so from there, what you're going to do is then continue to do the cleanup. And you can see I had to do a little bit more. I got it bleeding because of the amount of flash that I had. Also utilizing quick strips in between and what I call bikini strips, or GC makes a nice product of different types of strips to go in between the teeth as well. And this is what it's like when you get done. Now, the patient did heal for a few days, but this is where I injected molding the arch even into the posterior. One thing I failed to mention earlier is when you're doing injection molding in the posterior, it works really, really well for the anterior. In the posterior, it does work pretty well. You just need to have adequate thickness, and sometimes you're lacking that in the posterior. Also, you're going to want to have at least 2 holes in the injection molding PVS. And one is so you can actually inject into, and the other hole is so the air can flow out and the flowable composite can move through it a little bit better. And that's just something you need to do in the posterior. Then moving on to step 11, then you're going to do final smoothing and occlusal adjustments. So, you can take a look at things. You want to have good anterior guidance and excursive movements. And you want to have the teeth hitting where they should be hitting and not hitting throughout that area. And then you're going to go through your final polishing and finishing, utilizing whatever materials that you want to use with that. So some of the armamentarium that helps to make this good, you just have seri saws, 12 blades, quick strips. The Epitex strips by GC is what I was talking about earlier, as far as they have different grit of the strips that go around the area. And also some of the other finishing polymaterials that enamelize with Flexi Bluff, or any of the points or cups from Cosmodent and Flexi discs. And also GC has the 2-disc, and I can't remember the name of them right now. It's a 2-step product for, polishing composites. And honestly, it's kind of my go-to, because all you need is those 2 steps and things will shine very, very nice with them. So here's some of the tips and tricks with this. A big thing that's important is you want to have optimal tissue health. You can't take a patient that's going to be bleeding like crazy if you look at the gums and do this. You need to make sure that they're in good shape, they're clean, they've had a prophy. Sometimes I will apply a product by Ivoclar called Cervatec, and it's a chlorhexidine varnish to the teeth prior to doing this, like a week or 2 prior. And what it does, it just really helps that tissue to tighten up and be nice and robust. A big thing is avoid etching or bonding on the neighboring teeth. Sometimes if you're using just regular old Teflon tape sold at Home Depot, the white kind, the etch will actually eat through that, and you will still bond the teeth together. And that's where the yellow tape comes in, being a little bit thicker. It works, and also dental tape that dental companies sell. You're going to do every other tooth, Teflon tape on the non-bonding teeth. Another thing to remember, print at the highest printer setting for your models, 50 micron at a 0.03 surface layer height. Again, you'll need to have adequate facial thickness. I always ask my lab to do an additive only wax up and then add 0.2 millimeters extra facial thickness. One thing to remember, it's actually difficult to do on acid erosion patients. Composite just doesn't do well in those types of environments. And also 2 holes in the posterior teeth. And also everybody wants to know, like, hey, what does this cost? What are you doing? Well, honestly, I build this for what a cost of a core build-up. Now, when I'm doing my cases, I teach at the Pankey Institute, and one of the big things we talk about is you have to be billed for your time. And so I'll do a case workup, and I'm billing for things like time, like an attorney does. I take into account all of my lab fees, my materials, and what it's going to cost me to do everything, and I come up with it. Even though this technique, you're doing full mouth dentistry, I found it costs essentially, $400 or $500. I can do every single tooth. So essentially I can do an entire mouth like this in the low, $10,000, $12,000 range for a full mouth rehab. And that's really a deal, especially if you're, I don't know how many of you out there, you're trying to do some things for a patient and they're like, well, can you just do one tooth at a time? And if you're altering VDO or the vertical dimension, you can't do that. You have to completely change the bite for the patient. And so it allows me to do that. And we can do it in a manner that's just not too expensive. Now I'm going to show you, just kind of finish up here. I'm going to show you a few different cases of how I've done this. And so the first one's going to be like improving aesthetics and function. And so you can see with this patient, she just wanted some composite veneers. They were kind of chipping and breaking down. She didn't like the look of them. And so I was like, we can do a little injection molding with this. So you can see, starting just doing 8 and 9. And this is what it looked like when we got done. Not too bad. And so as you go through it, I want to kind of show you a few different things. One thing, I did it additive only, but you can also see the line at the bottom. And I don't really like how that looks. We got good line angles with everything. What I would do differently now when I'm doing this in that area is we want to hide that line a little bit better. And so what you need to do is you need to do about a 2 millimeter bevel, which you should do for most of your composites, like you can see right here. And so that's the 2 millimeter bevel in these areas. You can also then come through, and that's the 2 millimeter bevel had I done that on that patient earlier. Something else you can do is then take away a little bit more in this region. And what that does is going to help to make it look like you're developing the dentin underneath and the lobes of the dentin. And sometimes I'll go back and actually layer in some different colors underneath to kind of break up the edge of the line. And then on top of that, you can go back and you can injection mold. But this patient was very happy with the result. And it was something that it didn't take me long at all to do. It was very quick. Another case showing improved aesthetics and function. And this is actually the case that I showed you earlier. This is a friend of mine. He actually fractured tooth number 4. And the reason he fractured it is because he was guiding off of that tooth. Because you can see the diastema it's developed in the last few years. He's had a lot of wear on those anterior teeth. And so his canines and anterior teeth were no longer doing what they needed to do. Therefore, all the work was being done on the number 4, and he fractured it in the vertical fracture. And so that's something, sometimes people need negative consequences before they decide they're going to do a little bit better dentistry. And so, things worked out well. And I mean, look how much better he looks, and that's something done one morning. I think it maybe took me 2.5 hours to do that. And so it's a heck of a service for your patient. Also improving spacing. So this patient came to me and referred by the orthodontist. And what we ended up doing is, you can look right here closely. She had primary canines that were retained, and they wanted us to do some to evaluate for implants. And when we did this, I kind of looked at the case. I'm like, her teeth are small. They're kind of baby teeth. And those areas for the canines way too wide. And so I wanted to close those and actually space things out a little bit. So I utilize these overlays a lot. And you can see, if you put everything in there with ideal proportions, like we needed to change thing a lot. So we changed the orthodontics. So it gave us a little bit more spaces. We did a little crown lengthening on the anterior teeth. And so this is where we were after we took her out of ortho. And you're like, why would we take a patient out of ortho here? Just follow along. And so you can see we're a little bit more in the ballpark now for the spacing of what we need to have. I then utilize a printed guide to do some crown lengthening surgery to get it more ideal, like our wax up. Here's the crown lengthening. And then from there, this is her healed after the crown lengthening. And then I came back and did injection molding on the anterior 6. I then had things set up more ideally, so then I could go about and remove the primary canines. I did a guided surgery, implant surgery, placed the implants, and then provisionalized them. And then we let her heal for a period of time. And what I then later did is I went through and I did veneers on the anterior teeth, a little more injection molding on the posteriors to make it works. But, going from the left to the right, she looks a heck of a lot better. And I do need to include some of the final photos of her today, and it works better. But sometimes it's used as like a filler or a space to hold things. And then even in full mouth rehabilitations, this is the older lady that I showed you beforehand. What a difference, what a difference it makes in the looks and the function and how they feel. And then also, in other full mouth rehab, so testing out an occlusion or phasing treatment over time. This is actually the very first case that I ever did this way. And this is kind of what I showed you a lot as I was going along the step by step. And so you can see from the left to the right, that's the full injection molding. And what we decided to do, we were like, okay, we're going to swap out to a more durable porcelain over time. Now, a happy side effect that I didn't know that this would happen is many patients decide to go with the more durable porcelain or swap them out earlier, because what you're doing by putting this in there, they can feel it, they can see it, it builds the value. The patient's like, wow, I didn't know that it could be this way. It makes them more excited about having their teeth done that. And so she actually swapped out her, teeth for the more durable porcelain much earlier. And so this is her before injection molding. After the injection molding, you see it's polished, it's nice, good line angles, things look very, very nice before and after just the injection molding. So where we are today, the left is after the injection molding, the right is where we were. Now that's all the posterior teeth are actually swapped out for the for actual crowns. The anterior teeth are still injection molding. I just saw this patient about 2 months ago, and where we are today, this is her today. This is a 3.5 year follow-up. Still, she has in the posterior the actual crowns, but in the anterior, these are all the injection molding. I would say that they're wearing and they're staying polished. It's still looking pretty good. The tissue's still impeccable. Things are very, very nice. So this is a very, very good option for these patients. And the last little thing I want to share with you is a little informed consent. You just got to make agreements with patients. Like what I do is I tell these patients these are transitional restorations. They're not meant to be long-term. We need to swap these out over time. Now, most of them are going to go away. They're going to think that that's it. And if it breaks or they have a problem with it, I'll simply re-inject for the same price that I did last time, or they can then decide whether or not they want to swap out for the more durable porcelain. It's really up to them. But another part of the informed consent is something that is a little bit different, is when you hold a black light against this type of material, it is very luminescent. And a buddy of mine who I taught this technique to, he did this on tooth number 7 and 10 on a young girl going off to college. And she came home crying. And she's like, I can't go to the clubs. She goes, I look ridiculous. And what would happen is, as you can see here, is in a black light, the genial injectable really, really shines. Now, in my patient population, older type patients, they don't care. They're not going to too many clubs, and they think it's funny. But you can see here, it is something. So this is all part of the informed consent. And here we have my patient that I showed you a good bit, and you can see she has the posterior crowns, and they don't show anything. But against that black light, wow! Look at the anterior teeth. Now she laughed. She laughed herself to death. She thought it was hilarious. But again, this is something that you want to just be mindful of when choosing which types of patients you're going to use this for. And it is, if it's a younger patient, this is something you might say, hey, this might be an issue. I just want you to be aware of that. But anyways, I'm going to wrap things up and we'll do a little bit of Q&A. And I'd like to thank everybody, those of you who are out there. And please, if you, please have a very Merry Christmas. And what we're going to do is a little Q&A right now. So I'm going to pull that up. And let's see, start kind of going through some different things. What's the ADA dental code? Honestly, you can use, I use the core build-up dental code. I'm not sure what that is. You could even use like a composite veneer dental code, but they won't usually cover that. You could use like MIFL and just set it to whatever price you want it to be, but most any of those will actually work. Next question is, how will this affect those patients that have or need a mouth guard for teeth grinding? Yes, this actually will work pretty well. I'll actually utilize these types of this thing, and I just make them a mouth guard after I'm done with that. Like I said, it wears like any other conventional composite, so it does work pretty well. But some people are destroyers, and no matter what you put in their mouth, they're going to destroy it. And so you just have to kind of take that in consideration. And again, make these agreements with your patients. Will the material be able to take on the color of the teeth underneath? Do you recommend whitening before? Yes, always. Before I'm going to do any type of composite work, if the patient wants the teeth whiter, I will suggest that they whiten the teeth. Now, it is most all of these have a translucent effect to most of them. And so what I would recommend doing is, whitening beforehand, because you could whiten afterwards, but it's not going to get through that layer of composite that's already injected on there. So definitely whiten beforehand. Again, what is the code that you use to build this procedure? Usually I'm using the core buildup material code. And so the next question is, why 2 sets of trays with every other tooth if you have to use a full wax up matrix of every tooth at the second set for injection molding? So the reason you have the every other tooth model is so you don't have as much flash. That way, when you seat the every other tooth model and you're just injecting the ones that are there, it's going to be hugged up against the tooth that is not waxed up. You could utilize one model, the full wax up, and just inject. But what you'll find is you have a ton of material that will be flowing over onto the tooth next to it, because in that PVS, it's also at full contour. So you just have tons of flash and tons of cleanup to do. Now for small cases, I will do that really, really quick because I don't want to have to make it. But if I'm doing a full mouth or like all the anteriors, I will do 2 sets of models. How long on average do they last? Right now, I'm telling patients, 2 to 3, 3 to 4 years. Like I said, I'm at the 3.5 year mark with a lot of these. I've been doing this for 3.5, almost 4 years, and a lot of them working fine. I've had to go back and inject a few different areas. I've actually found the times when things fail for this is I have violated the minimal thickness, and it's usually on the corners or the area, and I didn't reduce enough or round the corner enough, and it's created like a pinch point for the composite to break. And so usually it's on me, but honestly, if you follow the directions the way the manufacturer says, it works very, very well. Another question, do you get very many fractures in patients over time and transition? Like I said, not too much, only if I'm violating the thickness. I'm not sure if you can go back and rewatch if you missed some slides. I guess you can talk to Viva Learning about that. Like I said, if there's something in particular, you can reach out to me directly and I'll be happy to share some stuff with you. Which software or lab would you suggest for crown lengthening guides? Most all of my the labs that I utilize will do that for you. I use Niche Dental Studio. I do a lot of this myself in exocad. I would just reach out to your lab and just tell them you want a perio guide. A perio guide is what they actually are called. And excuse me. What it is on the bottom portion of the perio guide is where you cut the tissue to, and then usually they do 3 millimeters above that. And so if you lay a flap, then you'll know how much osseous to do so you're not violating the biologic width. So again, they're called perio guides. I would just check with your lab. So I saw insurance won't pay core buildups codes until crowns are done. Yeah, that is true. I'm a fee for service practice, so that's just kind of what I'm doing. So I mean, just look at the surfaces that you're actually injecting. It could be a facial. It could be, I'd say call them MIFLs or MIFDs would be fine. And you could actually build it as a composite like that, and that would be perfectly fine. You just set the fee for whatever it is you want to do. All right. Thank you, Kevin. I appreciate it. Does the clear mold need to cover the entire arch if we were just inject anterior flowable? Can any flowable be used? No, it does not have to cover the entire arch. It just has to engage the tissue enough to cause a pinch point to where it's not just oozing out everywhere. You could possibly use any flowable, but the unique thing about this flowable material, GC's Genial, is highly, highly filled. And so it makes it strong, and it makes it where it wears really, really well. It polishes very, very well. It's the filler content that's in this material, and the rest of them don't have filler content quite like this. And the amount of filler that this material has is what makes it strong. And so, really, to do this technique, you can do that. Now, you can do it with any of the other flowables. It will work. How long it lasts, I don't know about that. Does this cause sensitivity? No, it does not cause sensitivity as long as you're following your bonding sequence the way it should be done. How to repair a chip restoration. You can actually either just do, if it's a small thing, you can just hand layer on top of it, or what you're going to do is remove enough of the material to create a path for the material to flow utilizing your original PVS matrix. Like I said, what is your cost per tooth? I'm charging around $500 a tooth at this point in time. I think earlier I was charging maybe $350, then $400. I've gone up in my prices a little bit because a lot of people are wanting to keep this around as the final restoration a little bit more. And the last question is, do you use this to show patients getting anterior veneers or crowns as a way to show the patient a post-op example without binding the composite to the tooth intraorally? I don't utilize this. It's much more expensive. If I'm going to do that, I'll do what I call a trial smile. I'll actually just do a regular putty matrix, just the two putties you mix together on my wax up. I'll then come in with a PVS flowable and do like a secondary, and then place the putty matrix back on top of the wax up. What that does, that's going to get all the little fine details and make it where it's much better. And from there, I'll then just take that to the mouth and actually just put Bisacryl, the regular tip area material, and put that over top of the teeth. And therefore, it's not going to stick to it. And that's actually my trial smile. I usually do pictures before and after, and it works pretty well. Like I said, I think utilizing this product and the ways we're talking about doing this, it'd be a little cost prohibitive to do that. But that's all I got for the question and answers. And I'd like to thank everybody for joining in. Again, you can reach me by my email and also through Instagram with this. And I would like to wish everybody a happy holiday season, Merry Christmas, and good luck with you. And try it out. It's a great product. Thank you.